Welcome to part 2 of our EAU Conference Highlights 2025. Coming up in this episode, we catch up with some guests at the EAU meeting, including Christian Gratzke, Sima Porten, Dunn, Yinjie Zhu, and a special walk around the trade area with Ben Challacombe to check out some of the new robotic surgery systems on display. Thanks again to our gold partners, Bayer China, who also support our conference highlights.
Okay, so very excited to run into Christian Gratzke. He's Editor-in-Chief of European Urology Focus. Christian, welcome to the podcast.
Thank you so much.
I always forget how tall you are in real life, especially in real life.
Well, it's great seeing you here, actually. Thanks for inviting me.
Wonderful to see you. What a great meeting, as always. It's not just an oncology meeting. There's a lot of benign stuff here, and you really take charge of all that. So you chaired a great plenary this morning on navigating the urge. So that's overactive bladder, really the A to Z of overactive bladder.
So thank you for asking me that. Actually, yesterday we had a session which is a collaboration of the Lancet and European Urology, which is for the first time giving us the chance to look at the global burden of benign disease. And I'm honored to lead the one project where you talk about the burden of benign disease on patients' life. And we're going to look at various areas throughout the world because the perception of symptoms in a patient is very different. So that's one of the aspects that I like to do. And then this morning, navigating the urge, I think for the practicing urologist, that patient that faces a patient, the doctor that faces a patient that has urge with or without obstruction usually considers various options. And we try to give them various scenarios in clinical life, pre and post surgery, and how to deal with those patients.
Yeah, and I think especially the panel discussions are very useful because, really, where does urodynamics really help? Yeah. If someone has a high post-void residual, does that really mean that they're obstructed?
Exactly.
These are the kind of complexities within that symptom complex to really tease out.
Absolutely. And I think there's a growing interest. We're lacking better drugs, which is apparent. We haven't had any better drugs for the last 15, 20 years. Beta 3 agonist, the most recent. And then when it comes to the new, more invasive treatment options, which we call minimally invasive, I think we need to consider which ones are best for which patients. So this individualized approach is what we're talking about. And there is sort of an algorithm to go from conservative treatment to drug treatment, and then the more invasive treatment options. We were lucky last year to present a late breaker on using an app for lower urinary. Yes. We just got published in New England Journal of Medicine Evidence, showing that interest whereby patients are happy to take on any conservative measurements, looking at an app to help them with physiotherapy, with conservative measurements, with knowledge sections, to actually improve symptoms. So the improvement in symptoms was almost as good as with tamsulosin, which I think is a good example of how those measurements might work in those patients.
Yeah.
And that can be used worldwide, even though you have countries with low and little access to money.
Absolutely, how interesting. And you also featured in a game-changing plenary straight after the Navigating the Urge plenary. Tell us about your work.
So that work was led by Manuel Ritter from Bonn. It's a Water 3 trial, following the Water 1, Water 2 trial. We looked at large prostates and did a randomized control trial looking at aquablation versus HOLEP or THULEP, so laser enucleation. We basically found that those modalities are equal in most primary outcomes.
Okay.
Aquablation is a little better when it comes to sexual function. HOLEP is a little better when it comes to reducing volume, so being a little more ablative. And the operative times are more or less the same. So I think there's a growing option that you can have, whether you would like the laser enucleation or the aquablation, but that seems to be an established treatment option in those patients.
So in these patients with large prostates, when you've got the options of aquablation or HOLEP, where does TURP fit in?
Well, I guess in the large prostate patients, there's little space for TURP. I'm a big fan of TURP, so in our department, any prostate up to 50 grams will be resected. Yeah. Because for one, I think we need to do this for the education of our residents. Yeah. They need to know how to do a TUR. They use this for TURBT, so they have to use it in a TURP in a small prostate. And also, my perception is that a HOLEP in a small prostate more often results in incontinence.
Oh, okay.
Because you actually put more pressure on the sphincter. So anything above 50, then you have a choice between laser enucleation or aquablation.
Yeah. And a HoLEP it's a challenging skill to learn.
Yeah.
So does the availability now of aquablation and the fact that it's now seemingly equal to HoLEP when it comes to dealing with these big prostates, does that make it easier for more urologists to be able to treat these large prostates?
Well, honestly, in our case, we have around 1/3 of patients. We do like 700 patients a year.
Yeah.
And 1/3 will be TURPs. Roughly 2/3 is actually HoLEP, and very, very few patients are getting aquablation. There is a financial issue around that. And then we have some clinical trials where we include patients with different novel approaches. But for us, laser enucleation is the mainstay of treatment in those large prostates.
In the large prostates. Yeah. Very good. Christian, I know you're going to be busy. It's a busy meeting for you, so I'm going to let you go. Always wonderful to chat.
Thanks for having me. Great, thank you.
Okay, so here I am with Sima Porten, one of my mentors from UCSF, big bladder cancer expert. Sima, it is so nice to run into you here.
It is very nice to run into you here, and I was tricked into this. I was told we're taking a photo.
And then I handed her a microphone. Now, Sima, EAU, have you had a good meeting so far?
I've had an excellent meeting.
Hold that close, yeah.
Hold her closer?
Yeah.
Okay. I've had an excellent
good
meeting.
Yeah,
Yes.
yeah. What have been some of your highlights?
I think there's a lot of development in the bladder cancer space, and I think that's been really exciting.
Yeah.
And the sessions were really thoughtfully put together at this meeting to kind of go through all the different disease spaces, all the areas where we need improvement, and there's controversy, as well as some real areas of progress.
Yeah. Now, we just had a chat with Sarah Sutka about the Sunrise 4 trial that she presented. TAR 200 is making big waves, and you gave a talk yourself about the development of the device. Tell us a little bit about your talk and the audience more about TAR 200.
Sure. So I went over a little of the history of the device, which was actually developed at Boston Children's and MIT, and it was a collaboration looking for a way to deliver sustained drug to the bladder. And the first kind of iteration of this was actually with lidocaine.
Yeah.
So TAR 200 is a silicone device. There's 2 lumens. The bigger one is for drugs, and the smaller one is a flexible wire that allows you to straighten it, insert it in with a catheter, and then it's retained within the bladder. And it's flexible, it's movable, and it stays there until you take it out again.
Yeah.
And so lidocaine was the first agent put in there, and because of the efficacy and response that was seen to that in patients with interstitial cystitis, the next kind of focus area was on bladder cancer itself. And then therefore gemcitabine was chosen as the drug to develop in that space.
Yeah, and we've seen a lot of evidence for its use in different stages, muscle invasive, non-muscle invasive. Where do you see TAR 200 in 5-10 years' time?
So I think it's going to be a really important part, and it was in the Game Changer session for a reason at this meeting. And I do think it's going to be relevant both in non-muscle invasive and muscle invasive disease, right? There are 3 trials that have not been reported, 2 of which are just completing enrollment, which is Sunrise 3 and Sunrise 5, and those are actually randomized control trials against the gold standard therapy, either BCG or, in case of Sunrise 5, with papillary disease, gemcitabine alone or mitomycin alone. So I do think it's going to play a critical role. I think it's going to be really interesting on how we use it in muscle-invasive bladder cancer. And kind of pairing with another session that I participated in on Friday, could we actually use this as a mode of complete bladder preservation without cystectomy, without radiation?
Yeah,
and how will it change the game in terms of those sort of concepts and ideas?
Yeah, I like that idea of bladder preservation. Well, exciting to see where it might go. Always so nice to see you, Sima. Enjoy the rest of your trip and have a great conference.
Thank you.
So we're in the trade hall, Renu.
It's massive, isn't it? Look at this.
And we met friend of the podcast, Ben Challacombe. Ben, great to see you, old friend.
Thanks very much.
You finally made it.
Yeah, it's been a challenging couple of days at Heathrow Airport, but we're here.
Yeah,
It feels better to be here. British weather, of course.
Yeah.
But, that's fine.
Yeah, that's been the theme of the podcast. Madrid, hey? We should have...
Well, this time Ben didn't bring it with him. It was already here.
So Ben, Ben's a urologist at Guy's Hospital, my old alma mater in London. And Ben, you're doing a live case this afternoon. You're doing a single port partial nephrectomy on the intuitive system.
Yeah, no, looking forward to that. Slightly daunted to do the first time I've done a live case with the SP, but we've had it for a year.
Yeah.
And I've done about 60 cases now, half of which are partial. So But we've got a nice case. I think we can demonstrate the system nicely. It's,
Okay.
it's a good system.
But while we have you in the trade hall, we thought we'd go for a little walk around because there's lots of robots in
It's
this
like
trade
doing
hall.
some window shopping. Shall we
Yes.
do that?
Yes.
let's
Okay, we're going to walk and
check
talk with Ben. So first up, Shurui, one of the Chinese robots. Ben, what do you think of this? Do you know anything about it?
No, I don't. I mean, this is a first for me, but that's the joy of coming to a meeting like this. So this is a replica of the Da Vinci single port from a Chinese company.
We're looking at it over the shoulder there. You got a shot, and David, you can have a look at that robot if you want. Here it is. While you're
if
chatting,
you
Ben, a
look
single
at the
port
active
system.
arms, it looks very, very similar.
Yeah.
Similar angles.
Yeah, it's very cool.
It looks very spacey. The actual construct of the design of the robot itself.
It's got a great elbow, hasn't it?
Yeah.
Yeah. Yeah.
So that's definitely a 90-degree elbow, which is what I think it's all about on that.
And we'll have to chat to the Shurui guys.
We'll have
and
a
see.
chat with them. They're obviously a new player, and this is the first time I think they've been at this meeting. So
And David, it
excited
looks
about
very
that.
industrial. I love the look of this robot. It's got these fabulous kind of hydraulic-looking things, and
cables.
cable. Well, it's probably about 25 millimeters, we reckon, is it, or something like that? Looks like that.
And they've got their own little gel port.
Yeah.
And a sort of similar
An assistant port,
access
yeah.
port, and
Yeah.
the assistant ports coming in down the side.
Yeah. I'm very impressed with the amount of flexion they have on that
This looks like
thing.
the,
What do you think?
This looks
Yeah,
like the
it's
real deal.
impressive, isn't it? Look at that.
It's amazing how these things just come out of the blue. You know, we're still getting used to single port from Intuitive, which does look like a beautiful bit of technology. And then all of a sudden, bang, the Chinese turn up here with a machine that looks incredible.
Well, that's more than 90 degrees. I think it's doing, I would say that's about 130 degrees there.
Yeah, it is incredible, isn't it?
And Da Vinci have just improved their SP to go from 70 to 82 degrees.
Yeah.
So it looks to me that this is already doing a more angulation, because that's one of the criticisms of the SP is it's elbowed rather than wristed.
Rather than wristed, yeah. I remember Mahir Desai was talking about that recently as well. Yeah.
One thing I do love about the single port is the way the camera kind of moves around the instruments. I mean, that's something you just don't get with your traditional robots.
That's part of the technique of doing single port, isn't it? I mean, you're moving the whole thing around a bit, Ben, aren't you?
You can
kind of
move
stay
the
in
whole
a
thing,
cone.
or you can adjust individually. But when you show the picture to patients of the instrument, they get it. They immediately, conceptually, they go, oh yeah, no, I understand that. 4 snakes coming out of one snake, and you go, yeah, well, like a Medusa's head, or like a. You know, they understand the concept very easily.
Yeah, it's awesome. Like the look of that. We're going to come back and talk to these guys and see what they say about it. Yeah, get a nice wide shot of that there, David. It's a beast of a thing, you know? Yeah, very cool. Should we see what else we can find?
Yeah.
Very cool. It's a pretty impressive trade area, isn't it?
It is amazing. These booths are massive.
Yeah, they really are.
Not quite the scale of ESMO, I think, but this is it's pretty impressive.
Let's wander down this way. So one of the other systems we want to go and see, Ben, is the Edge Medical Robot. I know a bit about this one. They've sold a few of these systems in in Indonesia. It's a company from Beijing, and I know they're here as well. And their robot, there it is over there. Let's wander that way, Renu. We're going to go past the Medtronic robot on the way. So you know this robot very well. You routinely operate on 4 different robot systems at present, don't you?
Yes, I'm not sure that that's a big claim to fame, but it is. But it is certainly interesting, and I think learning a new robot is easier if you've already tried a different robot.
Yeah.
So if you've learned one, then learning the third is easier, and learning the fourth is easier.
Yeah.
We've got the Hugo from Medtronic at Guy's. We've done about 100, almost 200 cases on it now.
Yeah.
Very good for pelvic dock. Very good for prostates. We've done a little. Just got a publication accepted showing no difference, 50-50 for prostates. And I use it retro or trans for kidneys. We're going to use it for bladders. That's the next step. We're going to use it for some reconstruction, but I've done some little RPLNDs on it. Nephro U's. One of the criticisms is its reach isn't quite as good, but the vision is brilliant. The angulation and the suturing is brilliant. So I think it's a nice piece of kit.
And an open console?
Yeah, that's right. That's the other big difference, isn't it? The open console.
The open console is really good for the communication. So if you set the theatre up and you speak to the assistant and the anaesthetist and the scrub nurse, you can see them all in line of sight.
Yeah.
So it's like, where is this? Well, you can see that they're getting it ready. There's none of that. And in an emergency, I think it's easier to communicate, or in a higher stress situation. The students love it because they can all kind of crowd behind you with the glasses and have a look, so you can teach more people at the same time.
Yeah.
So education-wise, I think it's quite a nice robot for that. That people can actually see your hands moving as you do the steps, and they can actually see your movements. Where in a Da Vinci, it's covered, so you can't easily see the surgeon's hands.
And it's well established now. The Hugo Rath's been around for a couple of years, and genuine competition in the marketplace.
Yeah, no, I think they're a major player. We've got them at ERUS this year. They're doing about 12 cases in London later this year with this system. So keen to.
Does that open console take a bit of getting used to when you're used to the intuitive system?
A little bit. There is a little mental sort of jump you've got to do. But unlike for me, I'm thinking a hard day, back, neck, intuitive, you can put yourself in whatever position you want. If you're in the wrong position, it's your fault with this robot, not anyone else's, because you can set your parameters. If you get a nice chair, you get whatever chair you want, pop it in. So I think it probably is good for those people who are worried about sort of strain on the body, and the ergonomics, of course, is really important.
All right, let's keep wandering. Let's go and find the Edge Medical. I can see it's over there. We'll fight our way past all this great technology. I mean, there's a lot of stone stuff, Ben. Do you do a bit of stone still? You do holmium lasers, I know, but
yeah, I do HOLEPs. The only stones I take out are when they're in a kidney that's dead or in a kidney with a pyeloplasty, usually.
Okay.
Occasionally, my colleagues send me patients where they've got a diverticulectomy, so we must have done about 20 of those over the year, of the bladder, but of the kidney, and you do a partial nephrectomy and then remove the diverticulum.
Yep. Ben, with the single port system, do you see yourself doing any transfer cycle prostate surgery?
Yeah, so that's a lovely use. I mean, and of course, weird that here we are after doing, I've done 20 years of minimally invasive surgery. People are coming up with new ways of accessing organs. We've got the transverse cycle and the low anterior with the single port that are kind of new, well, relatively new concepts, or at least new to being mainstream.
Yep.
So yeah, transverse cycle, removing a diverticulum for that, very cool. Removing stones, and there is a lot of interest in doing actual BPH and even cancer resections through the bladder, particularly in patients with lots of multiple scarred abdomens and other reasons why they couldn't have a standard approach. So it's I suppose it's opening up the ability to treat greater range of patients with minimally invasive surgery.
Yeah. All right, well, we're arriving at Edge Medical, and these are not like little fringe players on the cheap seats in the trade area. These Chinese systems, they're investing big. They've got a lot of square meterage here at this, and as I said, I first saw Edge at the UAA meeting in Bali in Indonesia a few months ago, and I was blown away by how much it looked like an XI, to be honest with you. And that same weekend, they sold 4 of them in Indonesia, and part of it was selling the telehealth concept in Indonesia, like 200 million people,
lots
200 or 300
islands.
islands, and they did a telehealth from one island to another, and so here it is. But what are your first impressions, Renu? Have you seen this before?
I have seen the Edge robot.
We
saw it at ERUS. That's right. Yeah, I mean it's nice, isn't it? It's very sleek. I like that it doesn't look bulky.
It looks like an XI.
Yeah, you'd be hard pressed to find many differences in the setup.
You haven't seen it before? Okay.
I've seen it just briefly at ERUS. I've never had a go at it. I've never used it clinically. Yeah. We've got it at ERUS this year doing a telesurgery, which is going to be exciting. And
so that'll be surgeon in London at the ERUS meeting in September, and patient in Beijing or somewhere in China,
or abroad. Actually, there's a few options being spoken about at the moment. And of course, that concept seems a little bit. It's nice to show it, but where is that going? Well, actually, I'm now starting to understand that is that if you're a country such as the UK, where you have multiple small islands off the UK where they want good healthcare, rather than bringing the patient and their family in for weeks at an end to have an operation, we could actually build up the skills of that team using this technology. The same would be true for France or for Spain or just doing any remote surgery. So I think it's a really interesting concept that may grow.
At Microport, I think it used to be Medbot, and this is the Toomey robot. We've seen this before at ERUS, and I've seen it at the UAA as well. So again, this is a very highly regarded system, I think. Renu and Ben, are you familiar with this system?
Yeah, no, I've again seen this, not used it. It's not got any sites in the UK yet, but apparently that is on the brink of happening.
Yeah, because it is CE marked in Europe.
It's CE marked in Europe. They've got clipper pliers, so it's like an XI clipper pliers. They've got ICG.
Well, Ben's talking, David.
They've
shuffle
got
your way in there and have a peek at that
some
system.
energy stapling devices coming later this year.
Yeah.
price-wise, it's going to be very competitive with an intuitive.
With an XI, yeah.
I think it's going to be at a level where people are going to really actually start thinking maybe we should get onto this system, because it, as far as I can see, functionality-wise, it does exactly the same. And the transition, of course, the learning curve for a new robot is, can be several cases, 20, 30 cases for something like a Hugo or a CMR. You switch to this, the learning case is literally a few hours.
Yeah.
Because it feels the same, it looks the same, the instruments move in the same way, and it seems like the engineering is very similar to the XI.
And it looks incredibly familiar, doesn't it? And hey, there's Cash from the company as well. You were chatting to him earlier, weren't you?
Yes.
Yeah, let's have a chat with him. David, come on over here. We found Cash from Medbot. How are you? We saw you at the ERAS meeting. Good to see you.
He did, and ERAS was good to build up my stamina for a meeting like this, right?
Well, and it's standing room only here at the Medbot stand, isn't it?
We're fully booked until tomorrow if you want to jump on the robot.
Really? Okay.
Yeah, which is amazing to see the interest and the level of people's thirst for something new.
And where is the interest mainly coming from, Cash?
It's mainly coming from urologists, geographically. So I'm responsible for Europe.
Yeah.
So there is a lot of interest in Europe, but outside of Europe, so we've already installed a system in Kuwait. They did a telesurgery. We did the famous longest telesurgery from Shanghai to Morocco. Morocco has a system in Casablanca. We did the first robotic surgery case in Pakistan, literally this week. So the interest is worldwide. We have the two systems in Angola. So the rest of the world is really opening up, and its ability to democratize robotic surgery around the world.
And that telesurgery, I mean, just thinking about how things have come, I gather it's something in the region of 0.13 seconds for the vision, the energy, the diathermy energy, and the sound to go there and back to make that seamless. Is that the sort of figures?
It depends on various things. The type of network you're using, whether you have a fixed line or not, and the distance that you're using. So, 20 plus years ago, Professor Maresco did the
Lindbergh operation.
Yeah.
We have that in our theses and things. Yeah.
Exactly, and that was landmark. And it's taken us 20 years to get to the point where now we have 5G. So we can, like last week from Belgium to Shanghai, we set up the two robots, and we had a chicken leg in Shanghai, and delegates could just do telesurgery. And we just used the normal Wi-Fi of the conference center, which everybody was on.
Really?
Yeah, and so it ebbed and flowed between 150 and 190 milliseconds, right?
Yeah.
And so there was a little bit of latency there. And then Prof. Motri jumped on and he did a demonstration of it. But if you don't
notice much of that latency, so that's a 0.15.
0.15 you don't notice.
Seconds, so.
Above that you start to notice. So it's almost like you just need to do the operation like you were swimming through the water. But when you're doing it in much shorter, so if you're doing it within Europe, maybe from Europe to Eastern Europe or to Africa, those distances are much shorter.
Yeah.
So with the normal Wi-Fi, with nothing special, you can already get those latencies down and be doing telementoring, teleproctoring, and doing the case as well.
Yeah, so this has the ability to take a team who are not experienced and gradually build them up in a very efficient, ecologically efficient way as well, because people and patients aren't having to move to the point where they can perhaps do easier cases, and then and you could almost act as their mentor, but you can actually step in. And
that's the important thing. You can step in, so you can put them through kind of a series of, we're going to start with something simple, then once you've mastered that, once you start to do something complicated, I'm there. The interesting thing is, on the learning curve of robotics, as you know, Ben, really well, you can do the first cases and you do start with something simple, right? And you master that by 20 or 30 procedures. And then you want to try something complicated. But the proctors and the company is gone.
Yeah.
Right? They're not there. They're not going to support you in your 40, 50th
and then
case.
You're vulnerable.
Exactly.
And that's when some series kind of fail, don't they, at that point? Whereas this wouldn't happen. It would almost be making it much more robust, that learning.
100%. You need to make sure when, I call it the second learning curve. When you reach that second learning curve and you jump to a more complex procedure, using telesurgery, we can ensure that there's an experienced proctor always there and can even jump in if they want to. So it is a revolution.
No, I see how that works now, and I think people will see how that evolves and look to that with a lot of hope for some of these smaller communities that haven't had access. So that's great.
We can really start to think differently about how we now employ this robotic technology around the world.
Well, it is exciting, Ben, isn't it? The democratization, as you say, and it's great to see the interest here as well. And good to see it, Cash.
I'll tell you, I had a call with my Australian team, and they're just gearing up with Tumai in Australia as well.
Yeah.
So
there you go. All right, great. Well, thanks. Good to chat to you. Let's stay wondering. So finally, we've made it back to the mothership, Ben. It's Intuitive Surgical. These are still the granddaddy of the surgical robots that have dominated your career and my career for the last 20-odd years.
Yeah, I mean, they're the obviously the exemplar system. Here they're showing off the XI, which has now been superseded by obviously the 5, Da Vinci 5, which is
not yet in Europe.
Not
I think.
yet in Europe, and my understanding is that will be here in a sort of the end of this coming financial year. So basically this time next year probably you'll have the 5. And they've also got their SP robot, which has been in Europe for a year now. We've been using that in our institution privately. Wonderful piece of kit. And they've got some new elements to it. And it's got greater reach and greater angulation. So they've got a few little things that they're showing off for the first time here as well.
Yeah, and these are pretty much, they've been dominated your career as well, Intuitive, and it's what, it's my entire surgical experience, unlike Ben, is based on these systems, and it does feel like getting onto your favorite bicycle and cycling along when I get on one of these
home
systems.
for a bit, yes, exactly, yeah.
And David, wander over there and you can, David will stick the camera in and look at the XI here first of all, and this came out about 2016 or so this is
I think
a very
photo of us in EAU 2015 or 16, because we've got one that's almost 10 years old at our place, and often robots, when you buy them in a hospital for a financial case, they look at 8 to 10 years use, and actually we think that this will probably go several years longer than that. They're showing no signs of wear, and they're passing all their checks. So actually this robot unusually may go 12, 14 years.
Yeah, I remember they said that at the time. This is not going to be something that you're going to be throwing out in 6 or 7 years' time. And it's interesting to put it in context when you look at these Chinese robots. They are mostly the Edge Medical and the Toomey robot are like this system. So this is quite old technology by Intuitive standards.
But we don't know if they'll have the longevity of these systems, if the machine.
We just don't know that.
The engineering will be the same. We don't know. I mean,
hundreds of thousands of cases. Yeah, but they still are. It's a fabulous system, isn't it? And Ben, I suppose, harking back to 2004, 21 years ago, when Prokhor Dasgupta, your great mentor and supervisor of your PhD, put in that first Da Vinci standard system, 3-arm system that you and I spent a lot of time messing around with back in the mid
the docking arms.
Yeah, the little screws, and the short arms and the standard definition. But it is.
And they've got this table here, which is also a thing, and the Trump table. With an
unfortunately named table. We have one of them.
And that's very good because it syncs with the machine. So if you're doing nephroureterectomy or multi-quadrant work, you can use that. Our general surgeons love that. So that is a very interesting adjunct to that. It tells you that a degree of angulation and roll on it, which is also kind of nice.
We like that. And I actually back off the patient during a robotic prostatectomy. I do it pretty shallow for the whole thing, but then when I'm doing the apex, I bring it down to 22 or 23 during the case as well. So it is nice to have it.
But when you do that, which is
they
nice.
Do that. Let's wander over and see the SP, David, and because we don't have any of these in Australia yet, Renu, but we are shopping, hopefully soon. So the SP has only just been CE marked in Europe about a year ago. Ben was speaking to us earlier about his experience using it, but it's only just been approved in Australia. So Ben, we
make an appearance in Perth for our annual meeting.
Just a couple of weeks ago.
Just a couple of weeks ago to the trade hall.
But you have a lot of experience using this SP system now, Ben.
Well, it's been around since 2018. I think only the US had it until after COVID and everything settled down. They got CE mark just the beginning of 2024. So amazingly,
David, swing in there and have a look at it.
Well, in Europe are that there's about over 20 systems now, 10 of which are in Italy. The Italians absolutely love it. They've got 6 in Germany, a couple in France. We've got 3 in the UK now. There's 1 in Ireland. So it's bubbling along. The thing that affected me, my thinking about it, was that I thought that you would only be able to do about 30 to 40% of our work with it. It's actually turned out to be more like 60, 70% of our work. So the scope of practice in terms of radical prostatectomy, partials, nephro-U's, pyeloplasties, and you've got this amazing ability with this robot to go through a completely different approach, which is the low anterior approach, which is down low on the abdomen and sort of creeping up along the ureter to the kidney.
Completely extraperitoneal.
Completely extraperitoneal, and so for me it's like a double trick. You get the trick of the single port, but you also get the trick of staying out of the abdomen, whether it be extra or retroperitoneal or transversical. So it's the coding in your head is like, what are we doing today? There's like we go from the front or the back, we go intra or extra, we go, there's a lot of different variability in what you can do with it.
Yeah, really good. Yeah, and David's getting some shots of it there. It's kind of a monstrous-looking thing on the outside, but that insertion port is about 25 millimeters or so.
I think the reason it got a bad name is they didn't have this. So this is the access port, a Da Vinci access port. This is a large one, and we call this the fishbowl or the bubble. And the instruments go through that so that you can have the insufflation through that.
And this is the main port up here, David?
The main port docks into that, which is much more user-friendly than what they started with, which was just a large port here altogether, which you can't get tissue in and out with, you can't get assistance through it, you can't get bits of pathology like the prostate, you can pop that in there, or a bit of fat, or a bit of a bargain bundle, or whatever you want to put in there. So that's made it much easier to use for most people.
Wonderful. Well, there you go. What a fun walk around the trade hall that's been. Ben, thanks very much. And you've got a case this afternoon on an SP robot, a partial nephrectomy here in Madrid.
Better go and concentrate on that now.
Yeah,
thanks very much for having me and talking about the thing I love most, surgery, robotic surgery.
This might be a tradition. We might have to do this walk around. It's like for Formula One fans growing up in the UK, Martin Brundle, ex-Formula One driver, used to do this great walk up and down the grid where he's trying to talk to celebrities, the pit lane walk. So we might evolve into Ben Challacombe's pit lane walk.
That's right.
The pit lane robotic walk. Thank you very much.
All right, thanks very much. So we've tracked down one of our Chinese friends, Renu. This is Dr. Zhu, who's an old friend of ours from Shanghai. Nice to see you, Dr. Zhu.
Nice to see you, Dr. Murphy.
Please tell us about your institution and where you work.
Okay, I'm from China. I'm from Shanghai. I'm working in Yinjie Hospital, affiliated to the Shanghai Jiao Tong University Medical School. So I focus on the prostate cancer disease treatment and diagnosis and then sales.
Very good. And you're a big proponent for PSMA PET in staging prostate cancer. Has the meeting given you any more insight into the use of novel imaging in prostate cancer?
I'm very interested in the PSMA PET-CT or PET-MI to play a very great role in the diagnosis and the treatment in the prostate cancer. And before I come here, I have read the papers from Dr. Murphy, pro PSMA, lumpectomy, and huge studies about the PSMA. I think there's still some maybe debates about the PSMA, but it helps us to treat the prostate cancer more incision, more to help us not to do more, for example, extended surgery to help the patient faster recover from the diseases.
True, isn't it? It helps with patient selection and limiting the toxicity of node dissections and things like that.
Yeah, I agree. Yeah, that's good.
It's still one of the hot topics at the EAU Renew is about the role of pelvic lymph node dissection and indeed the role of PSMA PET imaging. We often talk about it on GUcast, including with our Chinese friends. So you do a lot of prostatectomies. Can I ask you, what's your view on pelvic lymph node dissection nowadays? Do you do for all patients, or it depends on PET, or do it for no patients? What do you think?
I think before the last year, the EAU in Paris, right? I remember I have the topic. A lot of literatures tells include the PSMA PET-CT. A lot of nomogram tells we can highly selected patient need the extended lymph node dissection. Before that, if the pre-operation the the parameter, for example, PSA level, or glycemic score or T stage shows high risk or very high risk, I will perform the extended EPIND. But after that, I will consider about the PSMA capacity, include them. And so before the last year, every high risk or very high risk patient come to my clinic. I will, after the diagnosis, I will give them the PSMA capacity, and I will consider the result up to your study to give him yes or no to do the PRND.
So it sounds to me like the EAU guidelines are very influential for how you practice. It certainly is, Renu. When we travel in China, the EAU guidelines are always referred to, and I've many times spoken to Chinese audiences who want to know what do we think about the new EAU guidelines. So everybody respects the EAU guidelines.
Yes. We all know this is the biggest exhibition for the urologist. We can learn a lot of things from here, and the EAU guidelines update always the first the newest studies and the results to give all the urologists to help us to change the treatment, to change a lot of things to help the patient.
There's a lot of talk about MHSBC again at this meeting, so that's very important for us as urologists. Been changing a lot, and the last time I was in China, I remember speaking to you and some of your colleagues about the use of ARPs up front for MHSBC, and I know urologists in China are very comfortable using ARPs. We saw the data from the ARANOTE study just a few months ago, which now means that darolutamide will be approved in the doublet setting. But the last time I was in China, darolutamide can only be used in the triplet. It was tied to the license. So can I ask you for an update on the use of darolutamide in MHSBC? Is it still only in the triplet that you use it, or can you use it as a doublet, just ADT and darolutamide?
Thank you. For the real world, actually, I only use the darolutamide for the triplets in MHSBC for high volume, high risk, and actually triplets help the patient have good overall survival and PFS. In the clinical trial, I have tried to use the doublets, just ADT plus darolutamide for the low volume MHSBC patient. I also get just like the data from the ARANOTE. The first thing I think is very important is it's very safe. Not a lot of AE or SAE during the treatment. And another thing, it also improve the OS and the PFS and let the PSA reduce very fast and very good. So I think if the insurance or politics allowed us to use, I think it's a good option for us to use the doublets ADT plus darolutamide for the MHSBC in China.
Very good. We'll have to leave it at that, but thank you very much for coming to chat to us, Dr. Zhu, and we look forward to seeing you back up in Shanghai sometime soon, maybe.
Thank you very much. I hope to see you next time, maybe in Australia.
Safe travels.
Thank you.
All right, so here I am at the European Urology booth, and I'm here with Rod Dunn. He's a statistician for European Urology. Rod, welcome to the podcast.
Thank you for having me. Hi, Renu.
I'm good. Have you had a good meeting so far?
Oh, excellent. I love coming to this meeting.
It's a busy meeting for you, isn't it?
It is, yes.
Yeah.
There's lots of activities. And we won't even talk about all the,
all the
drinking
things you do.
and the food.
All that activity, yes, absolutely. So, statistician for the Platinum Journal, what are some of the challenges you face in your role?
Challenges is figuring out how to effectively get papers through review, but also what we're there for is to assess the quality. Statisticians do not typically get into accept, reject type of decisions. In European urology, we don't get papers until the R1 phase, and so our focus is really on just improving the papers, making sure that the methodology fits, but more that's being described well and that the results are being described well. The framing of all the results is correct.
And so by the time these papers get to you for a statistics review, is that already a good sign that it is going towards a publication? Or
yes.
Okay,
very good sign.
That's a good sign.
If it's coming to us, all the authors should feel very lucky.
Yeah.
They may not feel lucky once they get our comments back, but they're meant to be helpful. And
that's right, to improve the paper, absolutely. And so for people who are looking to submit a paper to European Urology or one of the other journals within the family, when would you advise people to get a formal statistics review for their paper before they submit?
When? Always.
Always.
In fact, I would start with reading our guidelines. We have 3 sets of guidelines. We have a 4th one that's coming out soon, so look for that later this year.
Yeah.
But we have one on just general statistical guidelines, one on figures and tables, a new one on causality, which is a major issue. People look for associations and then try to pretend there's a causal relationship. But if you review all of those things, your paper is going to be better if you address these issues ahead of time. I'm at University of Michigan. We have all of our people review the guidelines as they're writing, but then submit to a statistician for another review before it goes in. And then once they get to the formal review process, it's going to be a lot smoother.
Yeah, absolutely. And now you are going to be leading a writing course later. I mean, this is one of the great things about European Urology is, well, EAU really is that you do get exposure to all these things. And so, you know, if you attend EAU, you can get a course from the master. So you're going to be, tell us a little bit about the writing course you're taking.
Yeah, it's the 3rd year I've done the writing course.
Yeah.
And so we have your colleague, Declan Murphy, who's going to be talking about social media disseminating information out to the world.
He's pretty good at that.
But then we have a statistical presentation on what statistic gotchas to look for. We have one of the editors is looking for what editors are actually looking for in the paper. And then we go into the breakout sessions. I'm going to be participating in one of those where people we'll go through an actual paper that was published. And we'll find for a published paper what are the remaining statistical flaws.
Wow,
what are things that maybe you feel comfortable because you're seeing a significant p-value, but there might be other issues related to that data. And so it might require reframing, or maybe the answers aren't saying what you think they are.
Yeah. Well, we love your work, Rod. Thank you so much for your time and enjoy the rest of the meeting.
Appreciate it. Thank you.
All right, Declan, what a great meeting that was.
This is the end of our conference coverage for EAU 25, and what a better way to wrap it up we couldn't find than being at the EAU Black Tie Friendship Dinner.
I know, this is amazing. Look at that. Everyone's just getting in. It's time for cocktails, and then we'll have dinner soon. It's a great way to end off the meeting.
I have to say, you're if there were awards for the best glammed up urology podcasters, that's it,
Well, we don't go to this much effort normally for a podcast, but the occasion seemed to call for it.
It's a bit better than the usual GUcast merch.
The polo shirts, you mean? Yeah. Well, I mean, it was a great meeting, wasn't it? We saw some fantastic data out there. The game-changing plenaries were a huge highlight for me. We've pushed out 2 separate podcasts for those. The Translate trial, the NeuroSafe trial. Really great presentations. You were the discussant on the Translate trial. Very entertaining.
That was good fun. I did enjoy that, and you had a great plenary in the OAB session. It's been busy. We've been working very hard ourselves in this conference, but thanks to everyone who participated in the podcast, and congrats to the EAU Scientific Committee, Martin Alberson, and everybody who worked so hard to put it together. It is a fantastic meeting, and it's been really, really enjoyable, hasn't it?
Absolutely, and none of this would be possible without our conference partner.
Yes, so thank you very much, as ever, to our friends at Bayer in China. Bayer in China are gold partners of GUcast. They've been great supporters, and they're also partners for our conference highlights. So that's how we can put these little packages together and do all that.
Absolutely. Yeah, well, it's been a busy, fun-filled few days. I think we should go and have some more fun.
Let's do that.